Welcome to Grand Rounds for Rehabilitation and Movement Science for February 2023. As a reminder to everybody, please make sure your microphone is muted so we don't have feedback. Unless you're asking a question, then we absolutely invite you to unmute and ask that question. Today we have two experts in the field of pediatrics talking to us about idiopathic toe walking in the pediatric patient. We have Dr. Lisa Nekola, who graduated from Marquette University with a bachelor's degree in physical therapy. She then received her master's degree in business administration from Loyola University in Chicago, and she went on to pursue a doctor of physical therapy. And again, make sure you have your microphone muted, please. She then went on to pursue her doctor of physical therapy from A.T. Still University. Dr. Nekola is a board-certified pediatric physical therapist, and she worked in pediatric physical therapy for 34 years in a variety of settings, including DPT education, early intervention, schools, outpatient, long-term care, acute care, and rehabilitation. Her research is focused on pediatric interprofessional education opportunities, and Dr. Nekola currently works as the pediatric physical therapy program manager for physical therapy at St. Luke's. We also have Dr. Courtney Long, and Dr. Long graduated from Cedar Crest College with a bachelor's degree in biology and a minor in health and wellness. She then went on to receive her Doctor of Physical Therapy degree from Arcadia University. She has a passion for working with the pediatric population, utilizing a variety of treatment strategies to create a fun yet effective environment for children to maximize their function and mobility. She also believes that both a team-based and evidence-based approach to therapy is necessary to improve outcomes and achieve desired patient and family goals. As a reminder to everybody, make sure you sign in to EADS to get your CE and CME credit. And at the end of the presentation, as long as you had signed in, you will be sent a link for a quiz and then a course evaluation. Please make sure you complete both in order to get credit for this course. If you're watching the recorded version, that quiz and course evaluation will be automatically sent to you immediately after you are completed. So without further ado, I will turn it over to Dr. Nekola and Dr. Bachman. I apologize. I accidentally said her maiden name. She is now Dr. Bachman.
Okay, thank you, Steve. Thank you all for joining us today. Before we get started, we just have a couple things to go over. So this is our activity statement of need. This is the designation statement for St. Luke's. We have no financial relationships to disclose. And upon completion of today's presentation, the learner will be able to discuss the evidence, identify and evaluate the body systems, plan and implement treatment interventions, and explain the importance of early referral for children presenting with idiopathic toe walking. Idiopathic toe walking, also referred to as habitual toe walking, is a diagnosis given to a child who ambulates with a bilateral toe-to-toe pattern instead of with a heel strike. This diagnosis is often given to a child after 3 years of age, when they should have already achieved a heel-to-toe gait pattern. The Cross et al. In 2011 estimates that 7 to 24% of children receive a diagnosis of toe walking. A moment ago, we defined toe walking as a diagnosis given to a healthy child. To clarify, there are several pediatric diagnoses that may result in a toe walking presentation, of which we will cover later in the lecture. But idiopathic or habitual toe walking is a diagnosis given to a child when all other diagnoses have been ruled out. As we just mentioned, idiopathic toe walking is a diagnosis given to an otherwise healthy child. So why is this walking pattern of concern? Toe walking has been found to result in deformities in the bony structure of the foot, particularly the talar neck, tibial physis, and calcaneus. The findings in an article by Sinclair et al. In 2018 highlights the way the skeletal system changes form to adapt to function. And these changes occur rapidly in growing children. Furthermore, several ossification centers are absent in the newborn foot, and therefore susceptible to a history of use, including the navicular and cuneiforms. Therefore, these bones are flexible, mobile, and moldable, and as a result, we commonly see metatarsal spread and hypertrophy of the midfoot in our patients who toe walk. For these reasons, it is often challenging to find shoes that fit the child well. Persistent toe walking can also result in tightness of the gastrocsoleus complex. Often observed in our older children, a primary consequence of the shortened posterior muscle group is calcaneal eversion and midfoot pronation, particularly observed if we're trying to have the child achieve a foot flat position. The changes to both the skeletal and muscular systems reduce overall stability and decrease balance, increasing the likelihood of the child falling and potentially injuring themselves. Children who toe walk demonstrate an inefficient gait pattern. In an article by Neptune et al. In 2007, they found that there is a greater neuromuscular demand placed on the plantar flexors in order to overcome the poor contractile state and maintain the equinus posture over the entire gait cycle. Furthermore, due to persistent equinus posturing, children who toe walk have a decreased base of support, often with resultant decreased balance. Soangra et al. In 2021 reports that children with idiopathic toe walking are less stable during typical walking and prone to a higher risk of slip and trip-like falls. Now, in order to fully understand the implications of toe walking, we must first discuss typical or normal development of gait. Freeman et al. In 2022 nicely describes normal walking as a controlled fall, where the central nervous system coordinates the fluid muscle contractions and relaxations across many joints while monitoring body positions to maintain balance. For this reason, constant reminders to toe walkers to walk feet flat or feet down will not change the unconscious central nervous system abnormality of the gait pattern. Many of the muscles act eccentrically during gait to control forward momentum, therefore a controlled fall. During a normal heel to toe gait pattern, 3 rockers are present. The first is a heel rocker, consisting of ankle dorsiflexion during the heel strike, an ankle rocker where tibial translation occurs over the talus, and a forefoot rocker, which consists of ankle plantar flexion during toe off. Toe walkers often lack the necessary dorsiflexion during the first and second rockers, but 10 degrees of dorsiflexion is necessary during stance to have stability, efficiency, and control. Gage in 1991 reports that there are 5 prerequisites for independent ambulation: stability and stance, foot clearance and swing, positioning of the foot for initial contact, adequate step length, and energy conservation. These prerequisites are dependent on central nervous system maturation, motor control, and sensation, including proprioception. Gait patterns will change with any biomechanical constraints, including range of motion, strength, bone structure, and composition. Independent walking typically occurs between 9 to 15 months of age. A new walker will present with increased hip flexion, abduction, and external rotation, which are the postural compensations resulting in a wide base of support. The weight distribution is on the lateral borders of the feet, with calcaneal eversion and genu varus present. The postural components associated with walking are 1. Sufficient extensor muscle strength to support the body's weight on a single limb base of support. 2. Dynamic balance. And 3. Postural control in the form of anticipatory and integrative postural adjustments. And as new walkers continue to develop their independent ambulation, postural adjustments are made by the entire body. Here is a brief video depicting the progression of normal independent ambulation. As you can see, many of the common characteristics of the new walker gait pattern that were just discussed in the first clip. As the new walker becomes more experienced, the characteristic postural alignment will change and will be highlighted in the upcoming slides. Okay, bear with me 1 second. Okay. As a toddler progresses with independent ambulation, their postural alignment will continue to develop. After approximately 6 months of independent ambulation, their base of support has decreased, they spend more time in stance, and the amount of steps per minute or cadence has decreased. A heel strike should be consistently observed after approximately 6 months of independent ambulation, but certainly by 24 months of age. Less genu varum is present, and there is an increase in knee extension during the stance phase. During early phases of independent ambulation, it is important to remember that falling is part of learning. In an article by Adolph in 2012, they reported that 12 to 19-month-old toddlers will take on average 2,368 steps and will fall 17 times per hour. So practice does make perfect. By 3 to 3.5 years of age, the child's knee positioning moves towards increased genu valgus. However, the calcaneus is less everted. Upon heel strike, the child will demonstrate knee flexion in early stance. Balance reactions continue to be refined. At this time, it is important to note that the visual and vestibular systems are still immature and can contribute to an immature gait and decrease control of balance with perturbations or challenges in the environment. By 7 years of age, a child has achieved a mature gait pattern with improved walking velocity and increased step length. The heel position is neutral at this age. So now, as physical therapists, we will take you through our evaluation process, highlighting information that may be considered a red flag for differential diagnoses and/or referrals to other healthcare specialists. The subjective part of the evaluation can provide significant and relevant information regarding the child's overall presentation and their prognosis. Birth history may reveal prematurity, which increases the risk of abnormal muscle tone and potentially a diagnosis of cerebral palsy. Toe walking may also run in the family. In fact, Pulmonaro et al. In 2016 found that idiopathic toe walking is mostly seen in boys and has hypothesized that there may be an autosomal, X-linked recessive inheritance pattern, accounting for 30 to 70% of cases, although further research is still needed. When asking families about skill development, it is common that a child who walks on their toes has delays in one or more areas of development. We will touch on some of this information later in the lecture. While talking with the family, it is important to understand when the toe walking started, because a sudden onset well beyond the initiation of independent walking may require a referral to neurology. The frequency of toe walking is also important and can provide information related to sensory processing, range of motion restrictions, and the severity of the abnormal gait pattern. There is some evidence in the literature that suggests that children who toe walk also have one or more of the following diagnoses: speech, fine motor, and/or gross motor delays. Engstrom and Tedroff in 2012 reported that of the children with a neuropsychiatric diagnosis, such as ADHD, anxiety, eating disorders, etc., or developmental delay, 41% of them currently toe walk or had a history of toe walking in the past. As PTs, we typically complete a systems review during the first part of an initial evaluation, perhaps when the child is walking back to the exam room or during the subjective portion as the child moves around and engages in play. The key systems that will be discussed today include the sensory, neurological, and musculoskeletal systems. However, it is important to assess the integumentary system for signs of calluses or skin breakdown, secondary to abnormal pressure distributions on the feet during toe walking. Energy expenditure during walking and/or running will give information about the cardiopulmonary system. This will provide insight into a child's ability to keep up with peers and engage in age-appropriate play. Lastly, it is important to consider the child and the family's cognitive and learning abilities as you move throughout the evaluation and develop a plan of care. When considering all possible contributing factors to the child's tendency to toe walk, one must also look at the sensory system to determine if there is any hypo or hypersensitivity, particularly to proprioceptive, tactile, and vestibular processing. In fact, Williams et al. In 2010 and 11 reported vestibular and tactile processing differences between children who toe walk and those with a typical gait pattern. Often, therapists will provide families with the short sensory profile, a 38-item caregiver questionnaire, to assist in further understanding a child's sensory processing tendencies on a daily basis. Vision is also a key sensory system to consider during toe walking during the toe walking evaluation, although an in-depth assessment may be challenging depending on the child's age, comprehension, and any other additional diagnoses they may have. So what exactly is sensory processing? An article by Ayers in 1972 defined sensory processing as the neurological process that organizes sensation from one's own body and from the environment and makes it possible to use the body effectively within that environment. While the definition would certainly lead one to think there is a reasonable connection between sensory processing disorders and idiopathic toe walking, there continues to be limited conclusive evidence to support this link. There is, however, stronger evidence to link autism spectrum disorder and toe walking. In fact, Barrow et al. In 2011 reports that up to 20% of children with autism spectrum disorder toe walk for more than 3 months. Esposito et al. In 2011 reports that toddlers with autism spectrum disorder show higher asymmetry during walking when compared to neurotypical development. As quoted by Esposito et al., these findings suggest that toe walking is an early motor sign and most evident manifestation of a qualitative impairment in the motor domain of autism spectrum disorder. The objective portion of our evaluation will also provide very important information about the child's history of toe walking and their prognosis. We first take a look at the neurologic system, assessing tone and reflexes. Some red flags to consider here include abnormal reflexes. Upper motor neuron findings such as spasticity, hyperreflexia, or a positive Babinski sign could be indicative of cerebral palsy or spinal cord lesion. Moving on to the musculoskeletal system, it is important to look at passive range of motion and active range of motion when appropriate. Assessing range of motion will indicate if any muscle groups are tight, and of particular focus are the hamstrings, gastrocnemius, and soleus muscles. One must remember that more often than not, tight heel cords is often a secondary impairment from the toe walking and not the root cause of the abnormal gait pattern. Tight muscle groups will often also result in postural compensations at the ankle, knee, and hip. A red flag to look for during the musculoskeletal assessment is calf hypertrophy, which could be indicative of a muscular dystrophy, although careful differential diagnosis is important here. Lastly, we assess muscle strength via functional strength testing, such as heel walking, floor to stand transitions, squat to stand transitions, and we also do manual muscle testing when appropriate on children 6 years of age or older. Red flags to consider when looking at strength include proximal weakness, such as a Gower sign, which could be indicative of a muscular dystrophy as well. An article by Caserta et al. In 2022 found that children who toe walk were weaker in many lower limb measures, even when age and weight were considered. Additionally, when assessing all lower limb strength measures except for hip external rotation, children who displayed greater strength did not toe walk. After looking specifically at muscle tone, flexibility, and strength, we get the child up and moving to perform a gait assessment and various gross motor tasks. While watching the child walk, it is important to assess their quality of gait, including strength, muscle control, forward progression of the body over the foot, alignment, base of support, and center of mass. This is also a great time to talk with the family about the percentage of the time the child spends toe walking throughout their day. More information about gait will be discussed on the next slide. Looking at gross motor skills will provide additional information about their functional strength, balance, safety, and participation levels. Common gait deviations observed in a toe walker include significant ankle plantar flexion in both the stance and swing phases of the gait cycle. They also lack the first and second ankle rockers, previously discussed on slide 9 for reference, and a decreased third ankle rocker consistent with premature heel off. These changes in ankle rockers will further be explained as well. These children often out-toe or pronate their feet secondary to gastrocnemius tightness, particularly if they're able to comprehend the idea of trying to get their feet down while they're walking. Further postural compensations include knee hyperextension and an increased anterior pelvic tilt. In this video, you will see a 9-year-old male who sustains the equinus posture throughout the entire gait cycle. He lacks the first and second ankle rockers and has a significantly diminished third ankle rocker. One moment, please. Okay. Okay. Now for comparison, in this video, you will see a 6-year-old female who attempts to try to get her feet down while she's walking, but demonstrates significant postural compensations in the ankle and foot secondary to her tightness. Sorry, one last time. Okay. A more in-depth gait analysis will reveal abnormal gait kinematic changes at the knee and ankle in a child who toe walks. These changes include increased knee flexion throughout the gait cycle, with maximum knee extension occurring at initial contact. Perhaps the most notably obvious kinematic changes occur at the ankle, with increased plantar flexion during swing phase, which results in pre-positioning of the foot to have toe strike at initial contact, which you saw in both of those videos of the 9-year-old and the 6-year-old. There is an absence of an internal dorsiflexor moment at initial contact, which is consistent with the absent first ankle rocker. Additionally, the elevated mid-stance plantar flexion moment and diminished terminal stance ankle power generation is consistent with the absence of the second ankle rocker and decreased third ankle rocker.
Thank you, Courtney. Now we're going to be talking about physical therapy interventions. So generally, physical therapists spend much of their time working on managing the equinus, deformities or lack of range of motion, and gait training during our therapy sessions. In 2019, Williams et al. Published a study of survey results of greater than 900 healthcare providers worldwide, including physical therapists, orthotists, physiatrists, and other medical professionals. The survey addressed interventions for children with idiopathic toe walking. They found a wide range of treatment options. The interventions that were not supported by evidence. Many of the providers were unsure what evidence was really out there, and there was a lot of frustration reported by the limited guiding evidence. In 2019, Caserta et al. Published a Cochrane review of interventions for idiopathic toe walking, and they found that there was a lack of evidence with a control or comparison group. So during our literature search, we found many interventions used for toe walking, and the next 2 slides will detail this, but we found everything from observation to stretching, serial casting with and without Botox, using different types of footwear and orthotics, surgery, biofeedback, verbal reminders, taping, gait training, home exercise programs. There's quite a lot out there. But the 2 interventions we did find with supportive evidence are serial casting and surgery. So Lacrosse et al. In 2011 published the evidence-based guidelines for idiopathic toe walking through Cincinnati Children's Hospital. They found that serial casting was effective for some children. Engstrom et al. In 2013 found no difference between serial casting alone or combined with Botox. Both groups saw an improved ankle dorsiflexion range of motion. For surgery, it's often they'll do Achilles tendon lengthening or some type of lengthening within the gastroc muscle itself. It has been found that plantar flexion power is below normal 1 year post-surgery, and over lengthening of the Achilles is possible, causing more weakness. So surgery is often reserved for older children when more conservative treatment has been found unsuccessful. So To talk a little bit more about serial casting, the purpose of serial casting is to gain ankle passive dorsiflexion range of motion. A series of casts is applied over approximately 6 to 8 week time period. The physical therapist will take measurements of the child before applying the cast and each week thereafter. The child, when they put the cast on and with a cast shoe, they are usually able to walk and participate in their daily activities without difficulty. Sometimes they may have some balance problems, especially like in their physical education class or out on the playground. But the one drawback is that the cast cannot get wet. And the parent removes the cast the night before. And then they come in the next day and have another cast put on. And this goes on for a few weeks. Some precautions to note are the child's behaviors or intolerance to casting, the family's compliance, and a child's impaired lower extremity sensation, poor skin integrity, or impaired circulation. In 2021, Barkesi et al. Published a study of 5 participants with autism spectrum disorder who were treated with serial casting and AFOs for gait training. And they found that all 5 participants showed improved ankle dorsiflexion range of motion. A limitation is the very small sample size. As physical therapists, we often will resort to different splints and bracing to help manage the equinus contractures or prevent further loss of range of motion. Some of the benefits of orthotics and splints are to improve the foot alignment, improve kinematics during gait, improving ankle dorsiflexion range of motion, and prevent contractures. On the photo on the bottom left is of an Ultraflex night splint. And the nice thing about this splint is there's a hinge in it with a spring. So you're able to adjust the tension of that spring. But the child wears the splint at night, and the splint will push into plantar flexion. But as the child falls asleep and relaxes, the spring-loaded hinge allows that splint to then go into dorsiflexion, providing a prolonged stretch of the foot. The second photo is just of a solid ankle foot orthosis. The middle photo is of a SureStep supramalleolar orthosis, which helps provide foot stability and some negative reinforcement to the calf musculature when they try to toe walk. And the last photo on the right is of a AFO with a wedged heel. And this is a hinged AFO. The nice thing about this AFO is it allows full contact of the foot with the ground. And you can, the child can then work on heel strike during gait. And this obviously accommodates the plantar flexion contracture. Now I want to show you a video of a child, a side-by-side video. So the video on the left is this child without braces, walking on their toes. And then the second video on the right is of the same child wearing a Cascade DAFO number 2, which is a hinged AFO, which allows free dorsiflexion, but provides a plantar flexion block. And as you can see, with the video on the right, this child is able to achieve a heel strike and more of a plantigrade foot position during stance phase. So Beverly Kuzik was influenced by Shirley Sarman, but she states in some of her literature that she works on finding the shortened muscles and paying attention to their role in posture, balance, and movement. And then looking nearby for those hypermobile or lengthened muscles that are underused and work on activating those muscles and getting them stronger. And then while you're doing that, teaching more effective movement strategies with the child, and then addressing the shortened muscles last. She quotes that we should stop manually stretching shortened muscles, poisoning and cutting them. They are not the source and are already weak. Shortened muscles are the result of trying to increase stability. We need to change the strategy in therapy. So as physical therapists, I already mentioned we work on the equinus deformity and we work on gait training. But some other interventions that we may add to our repertoire are eccentric strengthening of the soleus musculature, which we can do with climbing, either up ladders and rock walls, squat to stands, and stair climbing. Some therapists have tried elevating the forefoot to activate the dorsiflexors. So you can do this by putting the forefoot up on a wedge or a mat and trying to work on some balance that way. You can put a little foam piece in a cast shoe to elevate that forefoot and see if you can facilitate a heel strike that way in gait. That also helps to work on that posterior weight shift that these children do not get normally. Therapists like to, because as mentioned earlier in this talk, the lower extremity musculature and trunk musculature are very weak with these children. So we spend a lot of time strengthening the lower extremities and the trunk. And we also focus on balance reactions and standing. These children have spent many years up on their toes, and so their basis support is very small. So they don't often get their foot down into a plantar position. So we try to teach them what that feels like and how to facilitate those balance reactions. So I'm going to show you here a video on the left of this little girl. Maybe. Okay. And as you can see, she's working on activating her ankle dorsiflexors by lifting that beanbag up. She's also working on her standing balance on the stance side and her balance reactions. And then the next two photos are of the same child working on, she's sidestepping along the balance beam, and then she's squatting down and picking up different things from the floor. And while she's doing this, she's working on her balance reactions and standing, working on that forward tibial translation over her foot, and some eccentric strengthening of her quadriceps and plantar flexion musculature. Also, to help facilitate ankle dorsiflexion, we use scooter boards, so children can sit on the scooter board and pull with their feet, and also that helps to strengthen the dorsiflexors. Oops. We also work a lot on trunk strengthening, hip strengthening. So here's some ideas. We have a child here on the left doing some prone extension over the bolster, so she can work on facilitating both hip and trunk extension. And the same child on the right, also working on strengthening her extensors by lifting that large ball up over her head. You can increase the challenge of this activity by doing it on a balance beam or more of a dynamic surface, like a BOSU or a balance disc. So we also work on balance a lot in therapy to help teach those children what it's like to have their whole foot on the ground. So the picture on the left is a child just standing on a BOSU and working on her balance. You can also flip the BOSU over on the other side, which provides more of a challenge on the flat side. And this video is showing a child also working on strengthening of her feet and balance reactions. As you can see, she's very hypermobile in her feet and a little unstable there when she comes up on her toes. So some other ideas for standing balance. We like to do progressions. So we can start with just the balance beam and then add more difficulty to the task. So in this one, I'm going to show you a video of this girl. She's walking on the balance beam and then stepping over the hurdles, then stepping on the little stepping stones, which provides some proprioceptive input. They're textured. Then she steps up onto a step and then onto the BOSUs. There's some different height steps there to challenge her further. and take note of all the trunk compensations as she's doing this activity. We like to focus on sensory-based interventions if we feel that the child is toe walking due to some sensory issues. So we'll look at vestibular interventions, proprioceptive, and balance. So I'm going to show you a video of we've seen this child previously. In the video, she's pushing a weighted cart to try to give her some heavy work to do. And she also has TheraBand around her thighs to help increase the difficulty of this task. So lots of pushing and pulling help to activate the trunk musculature and provide that proprioceptive input. For vestibular input and treatments, we use the balls a lot, bolsters, swings, to try to meet those child's needs and then maybe get them more focused on working on their gait training. And this photo on the bottom left is moon shoes. So these are really fun to use with the children because when the child stands in it, it already facilitates a posterior weight shift, which these children don't get during gait. It also, the child can work on their balance. They can work on their, and there's some strengthening. So you can do some sit to stand, squat to stand, have the child take big steps, and even do some jumping in them. So they're very fun and very challenging. So taping is an option too, to help provide some more sensory and proprioceptive feedback to the feet. Again, these children don't often get their heels on the ground. So with the tape, this is an example of using tape around the heel. We like to provide some compressions to the heel prior to doing the taping, but then you can put a piece of kinesio tape over their heel, up over their malleoli, providing about 90% tension over the heel, but none over the anchors. You can also change the area of the foot to be taped and changing the amount of tension to try to achieve what you're looking for. Sometimes we'll use kinesio tape for as a dorsiflexion assist, or do some abdominal taping to help improve some strengthening and stability of the trunk during other interventions. So as physical therapists, we're always looking for positive outcomes. So some of our outcomes that we look for are full passive ankle range of motion of dorsiflexion of at least 10 degrees with the knee extended to help achieve a heel strike during gait. We look for a heel strike of 75% of the time or more while walking without the use of braces, and age-appropriate gross motor and balance skills. So there has a question out there: will idiopathic toe walking spontaneously resolve? Well, Engstrom and Tedroff did a study in 2012, and their cohort was over 1,400 children, and they interviewed parents of these children when they were 5.5 years of age. And they found that 70 of the subjects had or currently have idiopathic toe walking. And they found at 5.5 years of age that 30 of these children still walked on their toes, with the total prevalence of toe walking at 4.9%. They did find that children with developmental delays or a neuropsychiatric diagnosis had a greater prevalence of toe walking of 41%, but their ultimate results of the study that they found that greater than 50% of these children spontaneously resolved their toe walking. There was a study by Hirsch and Wagner in 2004 of 14 children who had underwent conservative treatment of toe walking between 7 and 21 years prior to the study. And they said that non-surgical treatment does not have a lasting effect, and that toe walking eventually resolves on its own, and surgical treatment should be reserved for those with a fixed ankle deformity. Again, this was a very small sample size. And another study by Davies et al. In 2018 had 43 adolescents and young adults who returned after treatment for toe walking at an average of 13 years post. There were two groups. One had active treatment of serial casting, orthotics, and Botox, and another group had a treatment with just stretching. They found improved ankle kinematics and muscle power in both groups, but they found intermittent toe walking in 49% of the participants. So some children will continue to toe walk despite full passive and active ankle range of motion, and toe walking can recur in some children. Despite that evidence, we still recommend referring to physical therapy. Physical therapists are experts in assessing the musculoskeletal system. We can evaluate the whole child and assess for differential diagnoses as like CP, muscular dystrophy, autism spectrum disorder, other muscle weakness, and sensory processing impairments. Our approach will vary depending upon the child and their associated medical complexities. The child's cognition or their behaviors or the family's compliance can impact our success in therapy. Some of these children do not tolerate interventions well. But some of the things that we recommend for referring to physical therapy is to help prevent loss of ankle range of motion, avoiding fixed ankle deformities, addressing other compensations in the lower extremities or trunk, preventing injury from tripping and falling. So we feel it's beneficial to still refer, and we can screen these kids and see what we recommend. In addition to physical therapy, we will also consider other providers to maximize the multidisciplinary approach. If our conservative treatment is unsuccessful, we will refer to orthopedics or physiatry. If a child has a language delay, we will refer to speech therapy. If the child has a sensory processing disorder, we can refer to occupational therapy. If the child has persistent or significant equinus contracture, we can then refer to orthopedics. If the child has signs of autism, we would refer to developmental pediatrics. Or if the child has signs of a neuromuscular disorder, central or peripheral nervous system disorder, or a myopathy, we will refer to neurology. So some good news. This year, the APT Academy of Pediatrics is hopefully publishing the Idiopathic Toe Walking Clinical Practice Guideline. So something for us all to look forward to, and hopefully we answer some of our unanswered questions today. So that is all we have for you. And if you have any questions, feel free to ask. And we have many slides of references that are available upon request.
Please feel free to either write in the chat or unmute yourself and just ask.
Scroll through the references.
And I guess one question I had for you, if we had further questions, do you guys have your contact information on here at all? Share that.
We can share it.
So it would be first name dot last name.
Yep, lisa.nekola@sluhn.org.
And Courtney.Bachman@sluhn.org.
Oh, we do have one other question. Are any of the sleeping braces painful to the child?
Usually not. If they are painful, the child's not going to wear them. So we try to make them or have the orthotist work on having them fit well so they're comfortable for the child. And the one that I showed has a spring-loaded hinge, so it allows full plantar flexion while the child is sleeping. But as the child relaxes, it gently pulls that foot up into some dorsiflexion.
And additionally, just like any other orthotic that we're going to have a child start wearing, typically we do not recommend that they wear them overnight the first night. So we will do a break-in period, just like we do with all orthotics, to make sure that they're tolerating it well, to make sure that there's no redness, irritation, or skin breakdown, and to make sure that they're able to sleep with them on. So we do a break-in period first to make sure that they're able to sustain it for a prolonged period of time.
Thank you. And the next one is, first off, thank you very much for your excellent presentation. Can you touch on the way early motor development patterns can contribute to development of toe walking?
Yeah, so we can touch on it. So when they come in for physical therapy, if they're developing or if they have demonstrated delays in any of the following domains, there is, just like the literature suggested, a correlation to those delays and toe walking. So what we will assess further is where those compensations are coming from, and how we can kind of intervene to better set them up on success for overall development. So it's kind of like a multidisciplinary approach, but we're able to assess them as a whole and see where those limitations lie and how we can intervene to appropriately set them up on a path to age-appropriate development across the board, not just in gross motor, but also referring to other providers if needed to help with that approach.
We found a lot of these children have a lot of weakness in their legs and trunk. So if that can affect all areas of their gross motor development. So, and also, if you don't have good trunk stability, it's going to affect your handwriting and some of your fine motor tasks. So if we can work on doing some strengthening and help get these kids on a better path, they'll be more successful in their school and play.
I think another thing too that kind of highlighted from the literature that we had reviewed was the fact of if there are other signs such as a language delay or signs of autism, early intervention is best to kind of minimize the progression of a potential gross motor delay or toe walking diagnosis. So there tends to be that correlation. So even other providers or therapists who might be picking up on some of these things, if they notice any symptoms or signs of weakness or delay or instability, a referral to PT may be beneficial just to kind of make sure that the child stays on the right track or is on the right track to not fall behind and develop some of that persistent weakness that could develop into toe walking.
And as Courtney mentioned, early referral is best. It's easier to try to nip something, to address it early than try to address bad habits later. And again, we would screen if the child didn't need therapy, we wouldn't recommend it. So it doesn't hurt to have an evaluation.
Awesome, thank you. The next question is, are there any long-term studies on how this affects these children as adults? Are they more at risk for orthopedic issues in the future or other issues in the future?
Unfortunately, the long-term research is not out there the way we would like it to be. There is some, discussion in the literature about chronic pain or osteoarthritis, but the research is very limited to draw conclusive evidence at this time.
The next question is, what do you look for in the sensory profile specifically, and how or when do you decide to, or how do you decide if and when to refer to an occupational therapist?
I think the sensory profile looks at different areas of the child's day. So they're looking at their dressing, feeding, vestibular,
tactile, proprioceptive.
Yep. So and then you would give them the profile, the parent would fill it out, and then the therapist can then look at it. You could have a conversation and say, I think it'd be really great to maybe send you to OT to address some of these issues. A lot of it is talking to the family and finding out if they're having difficulty with the child in different areas. Always keep an open dialogue, because some of this stuff comes out later, even during the sessions. You're finding, and so we always are keeping our OT friends in mind during our sessions.
And some of the categories in particular would be the vestibular processing, the tactile processing. There is like, are they hypo or hypersensitive to movement? So there's two kind of thought processes behind toe walking. So some of our kids, from a sensory processing standpoint, toe walk because there's increased input that they're getting on the balls of their feet when they're toe walking. So they're seeking increased input into their body. On the other hand, though, there are kiddos from a sensory perspective who will toe walk to avoid full foot contact of sensory input or processing of different surfaces or textures that they do not like. So we do see both ends of that in terms of sensory processing. So that's where other questions come into play, like how often do they toe walk? Do they toe walk in shoes versus bare feet? Do they toe walk in the grass versus the carpet versus the hardwood floor? So kind of creating a whole profile of what the patterns look like, and then using the short sensory profile to kind of support that. And often case for myself, after I have a family fill it out, I will take it to an OT colleague of mine and say, okay, so can you explain this a little bit further to me? What does this mean based off of the information that I've gathered from the family? And then we work together to kind of determine if it might be appropriate to refer to occupational therapy and what kind of information might be best explained to the family in that regard.
Well, thank you guys very much. Thank you for everybody for attending. Please, again, make sure that you complete the quiz, complete the course evaluation. And if you have any further questions, please feel free to reach out to either the course presenters or myself. Thank you.
Thank you.